The other spot, one that I glossed over, but like in thinking about retroperitoneal organs, how about before we get to kidney, anything with the adrenal?
Oh, absolutely. Adrenal.
All
Adrenals are always fun. That's another fun category that I like because, as my background as an internist, I'm like very sensitized to adrenal anything. So I always like enjoy when like I see other people struggling with all the complications that come with what seems to be a chip shot. Look at that lesion, pretty easy. Well, until the lung opens in your face and you're like, oh my God, can I really do it or not? Well, it's so adrenal lesions. Yeah, I've done several. And let me just like give like a good case. Like sometimes it's good to give like a good example. I remember this gentleman who was post liver transplant, had a liver transplant. So we treated him for HCC before, had a liver transplant. On his follow-up at 2 years, he's noticed to have a lung nodule. Well, that's not fun. You really don't, that's disappointing. What could this be? Maybe it's some sort of lung met. He was a smoker, so maybe. So like, let's just biopsy it and see what it is. He's a liver transplant patient. Let's just see. So we biopsied it and we found out that it was metastatic HCC. And I was like, what? Metastatic HCC hiding in his adrenal gland? That's unfortunate, a little bit unusual. We're like, well, what are we going to do now? Well, the workup showed that was his only lesion. So possibly it was from the native HCC that we were treated and it was hiding there. So what do we had to do? We had to ablate it. Well, first thing, you have to, be very grateful that you're not ablating a pheochromocytoma. Because if you're ablating a pheochromocytoma of the adrenal gland, you are going to have fun. The anesthesiologist is going to hate you. But regardless, you still need to prepare for both procedures pretty much the same. Just the expectations for pheochromocytoma are much worse than for a metastatic adrenal lesions. You have to alpha blockade that patient. And you're gonna go and open a book and like, oh, I remember something about phenoxybenzaimine, something. Yeah, no, guess what? Guess what? They're gonna go to the pharmacy and they're gonna tell you, we don't have it. And your patient is going to call you and it's like, oh, doctor, they said it's not covered. It doesn't exist. And you're like, oh, what do I do now? They never taught me anything else. And you're going to call Dr. Raissi is like, you're an internist. What else can I do? I'm going to tell you, just use another alpha blocker, doxazocin or prazosin, that you have other alpha blockers. So you want to block it. You're going to give the patient alpha blockers for 10 to 14 days. And maybe if he calls you and he tells you, look, my heart is feeling really funny, that's probably, see him in clinic. Probably he has developed reflex tachycardia. That's when you add on a beta blocker. And remember, you always start with alpha blockers before you give the beta blockers. Otherwise, you end up in trouble. So you did all the right stuff and you're ready for your procedure, which is this patient. So we were going to proceed with ablation. I discussed the plan with the anesthesiologist so they know. So immediately when they heard that, they said, okay. So I definitely need an A-line. I'm like, yeah, I think that's a good idea. Please place an A-line. Because these hypertensive crises can develop before the cuff discovers it. So you want to address it pretty early. And I told them, make sure you have whatever IV meds you need, because I don't keep this stuff around here in IR. So they were also ready. So do you want to go through the lung? Yes or no? We all need now the tricks as an interventionalist. Maybe put that right side down so the lung doesn't open up. If you are like me and you're like, you know what? This is too complicated. Just go through the lung and we'll do all these lung sealed things that have worked so well for us. Make sure you communicate with your anesthesiologist about the PEEP is 15, the tidal volume is 600. Oh, you're already planning a disaster for me. So make sure all those things are micromanaged the right way. So, so you're ready to ablate your adrenal gland. Realize a couple things about the adrenal gland. Where do most mets go in the adrenal gland? They go into the cortex. Majority of lesions are in the cortex. Some of them are in the corticomedullary junction. So really, you don't need to really plow your probe through that probe. Obviously, you need to go through the lesion, but try as much as possible not to burn deep into the lesion, because the catecholamines are mostly within the medulla part. And if it's a pheochromocytoma, you have no choice. You're just gonna bite the bullet and deal with it. But if it's a metastatic lesion, realize these few things. When you do your ablation, remember, when you start ablating, if you're gonna go all hard on the ablation, you're gonna pay the price, because the adrenal gland is going to dump all that epinephrine really quickly into the bloodstream. So don't do that. start slow. Start with a slow ablation, 1 minute, 45 seconds, 1 minute, 75 watts for 1 minute, and see how the patient responds. You can always continue to ablate. Like, yeah, your ablation zone is not going to be bigger, but there isn't really much harm of ablating what was already ablated. You can't really make a huge difference. So start slow when dealing with the adrenal gland. Stay away from its medulla if you can, and work very closely with your anesthesiologist to make sure that hypertensive crisis doesn't set in. And hopefully you've already done your homework of blocking the patient appropriately.
And I think, like, you know, just to back up and talk about what you already said, is like having that discussion with the anesthesiologist ahead of time, like have your meds ready, have your alpha blockade ready, because no one keeps that stuff in interventional radiology, and it's not like in the cath lab or anywhere familiar. So they need to have that on board and ready to go before the case starts. Totally agree.
Yeah, I agree. And we're very good about, like, we have a very active IR clinic. We see 400 patients a week in our IR clinic. So a lot of these things are really managed very well. And that has helped us a lot. I tell people, make sure you have an IR clinic. It really adds that level of quality to your practice.